providers. Pharmacists is one of the problems. We don't have enough pharmacists. And I feel sometimes disappointed and kind of pessimistic because I look at some of the, especially the big employers, chains, I'm not going to mention names, and I see that the pharmacist is really not available. It's really hidden. And that doesn't make it like a good place for you to go and ask some questions. So I'll go through some issues related to medication literacy, and then I will specifically talk about some of our work that we're trying to do to improve this issue. There is one more thing. When I hear the term cultural competency, I believe in that, but I think we need to also take it to a different level and call it community competency. Because the culture, is really not that easy to define. And I learned some terms from some colleagues about acculturation. What does it take for you to become more Americanized? And the other way around. How Americans become more Latinos in terms of some of the custom. But if we look at the culture of El Paso, it's going to be completely different than even the culture in Tucson. I believe that strongly. And we're a lot of Latinos there and a lot of Latinos here, but there are some differences. So that whatever community we're serving, that's where we have to become competent with. If there is a Chinese population, and that's the primary, we need to learn some aspects about Chinese culture, and I also believe linguistically competent is important if we want to be the most effective possible providers. So those are issues that I thought I have to throw in before I go on with my presentation. I do need to acknowledge we have been working as a team, and there's a lot of people that have worked with me in some of these initiatives. So the two at the top here are my main colleagues from my program, Amanda Loya and Jerry Sayas. But everybody else here has contributed to some extent. Lately, we added a couple of people from psychology, which have been extremely important to us. Psychometrics is what we have to deal with in terms of testing what we think works. And without these colleagues, I cannot do much, because that's their expertise. And as a pharmacist, I was never trained on that, but I have been sensitized that whatever we do for patients has to be tested appropriately to really determine, is this doing what we think? And these are the objectives of my presentation. I'm going to talk a little bit about some relationships between health literacy and medication use. Then I'm going to talk about what we're doing in terms of some of our projects. And then at the end, I may not cover this, but there are some interventions and skills and some tools that I added to this presentation. I understand it's going to be on the web under the Hispanic Health Disparities Research Center. So you could access that later. I don't think I have enough time to get into those. A lot of it is simple stuff. We just have to keep reminding ourselves. So health literacy and medications. One of the things that we know is about 1.5 million errors occur every year that are significant related to medications. And a lot of it is related. Is this automatic now? Hopefully. I'll leave it there. These things are pretty big, and about 1 million of that 1.5 are in the ambulatory care setting. Now I'm talking about medication errors that are done by patients, not necessarily that the pharmacy makes the wrong thing or the prescriber wrote the wrong thing. I'm talking about interpretation of medications that were orders that were given to patients. Probably very sensitive. So, do you know anybody, including yourself, that have some issues understanding medications? Do you ever feel like you understood everything if a medicine was given to you, one of your relatives or friends? Do you feel good about that? Or feel like there are some questions that we all have? Probably most of us will say, there are some issues. I can give you an example. I've been practicing almost 30 years pharmacy. Not until a couple of years ago that I worked on developing a curriculum for middle school students, did I understand OTC labels. You ever look at an OTC labels and try to read through it and see what's in there? And I'm a pharmacist that have been practicing quite a long time. Well, I learned some things a couple of years ago about OTC labels, so I think most people do have some questions. So these medication-related errors, they cause about 7,000 deaths a year. I'm not moving this thing. So one of the priorities in terms of the Institute of Medicine is medication management. There is an initiative from the federal government that could help some patients, especially the elderly, is the Medicare. Right now will reimburse pharmacists for what is called medication therapy management. And it's sitting down with the patient and looking at the medications and seeing if everything makes sense. But that's not being done extensively yet. But that's something that is right now is available. So there is a little bit of an incentive. It's not like they're getting a lot of reimbursement for doing this, but there is a little bit of incentive for pharmacists to do maybe a little more than what they have been doing in the community. This is one study that really opened the eyes of a lot of people. And it was a pretty good study. There was 395 participants. And what they did is that they gave 5 prescription labels to patients and basically asked them to interpret those. These are the medications that were used. Common medications, everything in there is a common medication. Amoxicillin, trimethoprim, guaifenesin, phenolidine, and furosemide. These are very common medicines. And they told them how to take them. So there are instructions for each one of them. And this is how they were given to the patients. Basically, you have the vials, just like you get them from the pharmacy. This is some of their findings. 46% of the patients misunderstood one or more label instructions, so almost half of them. And those, you could see the type of errors that were detected. A lot of dosing errors. Liquid forms is one of the big problems that we have in terms of understanding how to measure liquid forms. How the order is written by the physician, if it's a teaspoon, can be interpreted many different ways. But you could see there's also frequency of administration errors and duration errors and so on. One of the key things, and I think the previous speaker talked about, not only for somebody to say what they're supposed to do, but the next question is, show me, how are you going to do it? Now, of course, in the setting that we are now, not too many pharmacists will come out there and ask the patient, can you show me? But these are the kind of things that we really have to do to get the patients to have better outcomes. And that's what the ultimate goal is for all of us. So these are the rates depending on literacy level of understanding versus demonstration. So as you can see, if you have a low literacy level, from understanding to actually showing, there was a quite significant drop in terms of being able to do it. And the drop did apply, not as significant, but it did apply also for marginal or adequate literacy levels. Now, this is one of the most disgusting things from my perspective. We have been doing this for I don't know how many years. Before my time, there were auxiliary labels, and they are used, and if you get a prescription, you probably have seen some of this. We know that only about 10% of the people actually look at them and try to interpret what is it that you're trying to do. Now, these rates in here indicate the grade level of what's written in that auxiliary label, and in here, how many patients got it correct. Now, this particular sample were considered to be low to medium literacy level. And in here, this is the number of the percent that actually understood what these labels meant. There were all kinds of misinterpretation. So these things that we have been doing for years and years and years, really, do they work? Well, if you look at these statistics, Most of them don't work. You know, this one that says for external use only, some patients thought that there was radiation going to come out of them. Because as you can see, the skin looks like it's radiating something. So there was all kinds of misinterpretations about it. Some people on this one here say, do not take dietary or dairy products. They thought if I'm allergic to milk, I should not take the medicine. So there's all kinds of misunderstanding. And what do we do in the pharmacy? Most pharmacists out there will just put that little label on it and give it to the patient. Now there are some pharmacies that will actually tell the patient, you know, do not take this with milk because it could interfere with the medication absorption. Well, that clarifies this a little bit better. But then repeating back, if you're concerned about like a high-risk drug, we want to ask them, can you repeat the instructions of what you need to do? Especially if it's high risk. This is another study by some investigators in Minnesota, and they were basically looking at liquid forms and trying to understand, do patients know how to measure and administer liquid forms of prescriptions? In this case, they had an N value of 252 patients, and 77% dosed the medication incorrectly. So as you could see, this is a big problem, especially in the pediatric setting, and now there's less and less products that should be used in pediatrics because of what we know about over-the-counter products. So many of them really are harming children more than helping them, especially cough and cold medicines. So this is an example of the instruction. Give 1 teaspoon by mouth 3 times a day. Now, what is a teaspoon? I mean, we have them of all sizes. So when you go home, I mean, I don't, my father-in-law likes to use big spoons for the soup. So will that work? Or is it a little one? Is that too small? So we have too many choices here. So when we're writing teaspoons, we really have to be more precise. What are we meaning? It's 5 mLs, 5 millimeters. A tablespoonful is 3 times more. So if it's a high-risk medication, and you're giving it several times a day, this could be a problem in terms of toxicity. So this is the kind of thing that we're going to have to, you know, is teaspoon the best way to prescribe liquid medications? Now there are other, and I'm sorry about this a little fussy, but can you imagine if there is a grandmother that is helping the kid take this medication and her vision is not very good, she may even have more issues. But basically there are other ways to measure liquid forms, and pharmacists should be supplying some of this. So in their study, what they found is household teaspoon is the most frequently used device for measuring liquid medications. But we have done some testing, and what it looks like a teaspoon, we have measured, and it varies from 3.5 to about 7.5 mLs. And we try to keep them as close as what it looks like a teaspoon. And they're not precise. Depending on what product you buy or where you get it, you're going to have different measurements. And the most common error in this case was confusing teaspoon with tablespoon, which is 3 times the dose. So as you can see, it could be even more dramatic in terms of an overdose or an underdose. These are the best choices. The oral syringe, and pharmacists should be supplying this when you're picking up prescription liquid form. 92% were able to use that and measure it correctly. And that was followed by medicine cups. The cylindrical spoon was pretty accurate, but there was a lot of spillage. It was not as easy to manage. What about if you go, especially females that may be asked to take some calcium product. And they tell you, take 1 gram to 1.5 grams every day. And then you go to the pharmacy. This is a local pharmacy. This is not a big chain, so it's relatively small, the selection there compared to the big chains. Where you walk through these aisles and you try to determine, okay, what product can I take? Because there's a lot of over-the-counter products. So in here you have a partial list of what you may find in a pharmacy. Now, calcium comes in many different salts. So the elemental calcium varies. But what's on the label may be the total amount of the calcium salt, carbonate, citrate, gluconate, whatever it is. So you get into these kind of things, and I mean, this is the issue of, can I ask somebody to help me out? I need to take so much calcium. What is a good product? In here you have probably one of the cheapest, oyster shell. The absorption of oyster shell is the worst. So you have issues of absorption of the product besides how much calcium is really there. I'm going to switch a little bit about getting to the project that we have been working on for the last 3 years, and we continue. This is still in progress. There are some pieces that are pretty well advanced or almost at the end, but there's still some other work in some of the other pieces. So this was a grant from Paso del Norte Health Foundation when they had a health literacy initiative. This is gone now. Yeah. The transformation of Paso del Norte Health Foundation, this is one of the consequences that they have given up on some of these initiatives. But basically, they were interested initially about addressing issues with health literacy in El Paso. Our definition of health literacy is similar to the definition of medication, or our definition of medication literacy is similar to health literacy, is to obtain, process, and understand information related to medication use. So we borrow that definition because we're pharmacists. We wanted to address medicines. These are the goals. We had, first we wanted to do an assessment on 3 patient populations that we consider to be at risk. So you have older adults, pregnant women, or breastfeeding, and parents of young children. Those 3 categories were considered to be groups that were at risk. We also wanted to increase knowledge of Mexican drugs because we know about 1/3 of the population purchase medicines in Juarez. Now that's before all the crime. We don't know how that's impacting people going, but I think once the crime will hopefully go away, the levels that we have seen lately, we probably are going to see similar type of results. So some of the information that I have here is before the crime wave in terms of some statistics. But we do know about 1/3 of the population goes to Juarez. And then we wanted to develop educational programs for the community, and we wanted to assess 2 groups, healthcare providers and patients. Because we need to, it's amazing how little, when we gave some programs to pharmacists, how little they understood the problems of medication literacy. Our own professional health, pharmacists, they knew very little of what are the issues out there. So these are specific aims. We developed a bilingual medication literacy assessment tool, and we have conducted quite a bit of work on that, and we're at the process of finalizing the psychometrics. We developed a bilingual medication literacy curriculum. It was initially developed to be used by promotoras or promotores, but it really can be used by any healthcare provider. It's done in a way that we want to make it as extensive for people to use. And then we have some educational programs for community pharmacists, and we are extending that to nurses, physicians, residents, because I think we all need to be more sensitized about some of these issues. And then we also wanted to identify high-risk medications in Mexican pharmacies, because many of our patients are taking them. And I'll give you some example about that. We had an expert panel to give advice that included pharmacy, medicine, nursing representative, literacy experts, promotoras and promotores, lactation consultant, and the West Texas Poison Control. The first thing that we did is conduct some group sessions to get an idea of what are the issues that patients have. Because I think I know what their problems are. But I have learned I need to hear from the patients. What are the issues that they're dealing with? So we recruited from different zip codes, trying to have a sample that included low income, medium income, and high income. That way it's representative of the city. And we did place flyers in clinics, pharmacies, pediatric clinics, and so on. We did give patients that participated a $30 gift certificate. So we did use basically qualitative research methods. We had small groups, 5 to 10 participants. We presented some information. We had a group discussion led by an experienced bilingual moderator. And then we, of course, collected some demographic data. Type of questions that we use are listed in here. We wanted to know about what medicines, herbal products, Mexican products they were using, perception of written verbal information, and fears and concerns. This is some of the statistics real quick. The three groups that I mentioned, most of them are Hispanics, most of them are females. Of course, the older adult, the average age was 64. They were low income for the most part, and also low education level. This is some of what we found. This is current use of medicines, herbs, and over-the-counter products. Later I'll show you something a little bit different in terms of within the last 12 months. But basically, these are the statistics of the different groups. Using herbs in adults was the highest at 26%, over-the-counter 40%, and they were using Mexican drugs at 26%. And these are some of the average number of medicines. And of course, older adults will have more medications. This is considered polypharmacy, polyherbacity. When you add all these medications, you can see that there will be a number of products the patient will be taking. And the samples for pregnant and lactating women were smaller, except there was more of a use of Mexican drugs. So maybe because of the ability to go across, maybe easier for the younger population, they did go and purchase medicines. This is one thing that I asked. I insisted that we need to ask this. And it's basically, we wanted to know how many patients are telling us that the pharmacists counsel them. Now, do you know that by law, pharmacists should counsel every patient the first time they get a prescription? How many people knows that? 1, 2, 3? Well, that's the law. Every time you get a prescription, the pharmacist should come and counsel you, at least for the first time. If you have refills and no problems, they may not talk to you, which is too bad because you want to see more interaction. But as you can see here, parents of children, 60 were at the level of rarely or never. And of course, every group in here had a significant number that were not what we wanted to see. But the parents was the worst. Older adult, still a significant number. So pharmacists are not doing their job. So I'm a pharmacist, I feel bad about that. So these are the things that we have to change because this is not going to help in terms of patient outcomes. Some of the key findings from the different groups are in here. Some of them are not surprising. Harder time seeing small font. So we have an issue of labels. What's the right size of the font in the label for patients to be able to read them? And then there were other issues related to pregnant and lactating. They were most comfortable with product labels. Another one here, older adults rely more on physicians and pharmacists compared to the pregnant and lactating and parents of young children. Not surprising, some of these findings. More difficult for the older adult to keep track of the medications because of the number of medicines that went to take in. They really herbal products in town, and there are some things that you have to be very careful about what you do with herbal products. And then lactating mothers were less likely to use medication of any kind. So parents of young adults that were more concerned about child-proof packaging, and that rightly so, but they were more also likely to use Mexican products. And I'll show you some examples of Mexican products and why we are concerned. Not every medicine from Mexico is bad, but there are some, especially the ones that are offered by the clerks in the pharmacies, that depending on what condition you have, may be a problem. So this is a medication literacy assessment tool. We were basically testing these 3 or 4 areas: prose literacy, numeracy, document literacy, and problem solving. And we used case scenarios, and it was administered in both English and Spanish, and we recruited again from different zip codes. And this is the demographics. So you have the zip codes here, and medium household income. So we got a good representation, as you could see, from what the primary language was, the household income, and poverty level. And then this is comparison to El Paso, Texas, or the US. Scenario 1, I'm going to go through this very quickly, is basically insulin. And we just heard from the previous speaker about the problem of insulin misinterpretation, of somebody thinking that they were using it correctly. So this is one of the scenarios that we use. We call it diagram. In case there were patients that were familiar with diabetes care, we wanted to kind of give them a different name. It was recommended by one of our biostatisticians. Scenario 2 was children dosing of over-the-counter products. And basically, they were like ibuprofen. And there are some of the questions that we ask are listed in there. This was the Mexican drug products, and actually we went to Juarez and purchased some medications that are from Mexico that are similar to what the prescription that we gave to the patient was. And they needed to look at this and determine which one of these products is the one that I'm going to purchase in Juarez. Because what's happening in Juarez sometimes is that you go there with a prescription for Augmentin. Anybody knows what that is? Yeah, you do. It's an antibiotic, and it's a combination of an antibiotic and a beta-lactamase inhibitor. So it enhances the effect of the antibiotic. But amoxicillin can be sold by itself. It's a lot cheaper. So sometimes the patients will go across the street, across the border, or the street, and they will ask for Augmentin, and they say, you know, that's too expensive. You want to use amoxicillin. It has the same antibiotic. So that was one of the issues that we were trying to use. So there are some amoxicillin by itself in those boxes in there. The other thing that is interesting, there's a couple of issues. They're packaged in a specific amounts of medication. So in here you have 12 capsules. Now, depending on what you're treating, you may need to buy 1 or 2 or 3 boxes. But there were issues about just purchasing the box because it was thought to be, that's what it is, the box. Now, other ones have multiple quantities, like 100, and it was cheaper. So they could buy more. But is that what we want, that people stash a lot of amoxicillin at home for whenever they want it because they feel like they have a sore throat? No, I don't think so. And the last scenario was prescription and over-the-counter herbal type of issue. We recruited from basically every 5th patient from each one of the clinical sites that we went to. And if they refuse, we ask the next one. So to do it as much of a random sample as possible. And there were some issues relating to the different sites. At the clinics, we have more problems in recruiting. We have more issues with having to rephrase and explain some of the questions in the assessment tool. Took longer, and most of them were Spanish speaking. So at the grocery store, we had a different type of issues. It was easier to recruit, and it seemed like the people will understand more and so on. This is the number that we did initially after doing some basically some statistics. We added another 60, and it's being completed as we speak. So in order to make this valid and reliable, in every way that we can, we are collecting additional people. Because there were a couple of things that we have problems that we have to make adjustments. But basically, these are the demographics for this particular piece of the study. Additional issues in here is that, when you look at the last 12 months, the number of people taking herbals was almost 50%, and it goes on to a much higher level of OTC product use, and overall 35%. And this is consistent with another study that I did, that about 35% of the population purchase Mexican drugs. And again, we have a problem with how often do you counsel patients, by pharmacists. So we have quite a significant number that never or rarely counsel patients. Problem solved is another issue. These are examples of what we found. Who is the doctor you will call if you're out of refills? 52% answered that incorrectly. And this is giving them the label for the prescription, where the physician's name is in there. So 52% did not know or answered incorrectly when the issue came up about getting refills. About dosing OTC medicine, 40% got it incorrect. About basically half of it. When asked to measure 1.5 teaspoons using a 5 ml measuring cup, 58% got it wrong. When asked to demonstrate the dropper full of Tylenol, 51% got it wrong. When asked to identify 3 places to inject medicine subcutaneously, 43% got it wrong. And this is an example of how we also presented specifically how the issue of injecting the medication that's supposed to be like an insulin. 30 minutes before meals. So 70% were correct and identified that this was to be administered twice a day, but only 11% were able to identify a specific time of the day in relationship to the meal. So when you tell them before meals, maybe we need to be a little bit more specific and tell them 30 minutes before the meal. And it's only breakfast and dinner. Because other patients thought, well, every meal I eat 3 or 4 times, and every time I just inject it. Again, they're measuring 20% of the liquid. This is the measuring with liquid forms. 20% will choose a teaspoon from home as a preferred way of doing it. And 55% have done that. So the medication literacy curriculum is intended to help patients out there, and it's structured in modules. And it's first has been developed in Spanish, and we will be translating this into English. So there are 2 key areas. Increase awareness of risk associated with taking medications, herbs, and supplements, and encourage behaviors that may prevent adverse events. We have done the 3 phases of development, pilot testing and revision, and development of the evaluation tool and psychometric testing for the tool. We have done the first 2 for the curriculum. And of course, for the Mexican drug products, it's an ongoing process, basically, because and I tell you, we first look at the medication from Mexico, but we can't find a comprehensive list. So some of what we're finding, patients are bringing to us. And I'll tell you a little bit more about that and see how are we doing with time. So it's 12? Okay, so I have a few more things. Let's go through it a little quicker. I get to the most important parts. These are the different categories of the curriculum that we're developing for patients. And they may seem like a lot of topics, but they can be given by themselves depending on the need. And they're about 30 minutes each. and it does include some interaction, show me kind of thing. So they are short, even though the list is big, but we do feel like each one of these categories has some valid information. So this is already pretty much developed in English or in Spanish, and we're going to test it. We submitted for a grant to do some testing of the effectiveness of this. That way we could say that it did show what we intended to. Reading medication labels, just quickly. This is an over-the-counter label. And if you, by the way, it's in English, so our Spanish-speaking people will have to kind of get an idea of what information is in here. So we, of course, went ahead and did it in Spanish. It tells you what is it. Ingredientes activos, para qué se usa, advertencias, ingredientes inactivos, otra información, instrucciones. So we will present this kind of information and walk the patient through. That way they understand. And maybe some of you will also want to do the same thing. Now this is a prescription label. It's a little bit more complicated and it's a lot more information, but it's so full of stuff that you could see why people will have difficulties understanding or getting information from that label. And one of the things that I don't like is certain things should be highlighted more importantly, like the patient's name, maybe the medicine name, and the instruction. And some of the other things is not as critical. So, but this is what it looks like, and these are the different pieces of what's in that prescription label. We're also going to talk about, in this curriculum, about how to split tablets, because there are some issues. Pictograms, which the previous speaker talked about, we are also interested in using this, because we think that it can convey a better way of patients to understand how to take medications, because this is a common mistake. Twice a day versus 2 a day. I mean, this is pretty simple that before 8 o'clock, you take 2. In this case, before 8 and before 8 a.m. and 8 p.m., you take 1. So these pictograms we think are beneficial.
And those would be labeled on the can?
No, this needs to be done as an additional piece of information. The USPDA, which is a reference that we have in pharmacy, have something like 70 pictograms. So you could copy it and fill it in. This is if you really want to make a difference, especially if the patients seem confused, that they don't understand and they have more than one medication. So these are related to meals, before or after meals. So you could use the pictograms that way. And then you also have to make it clear what are the differences in terms of teaspoons versus tablespoonfuls. This is more of arranging several medications and when they should be taken in relation to the day. Some people prefer the clock, so we are also incorporating, if you want to use a clock, this is a way you could do it. Then there are patients that are going to have multiple medications, so we do have devices, like pill boxes, to be used where they can try to organize their medicines. This is what we did with the CE program for pharmacists, and we're more than happy to do it for other providers that are interested in learning more about the issues that are out there with health literacy. We all need to be sensitized. We're not getting the point across. We think we give these pieces of paper to patients and they understand. In the pharmacy, you know how they give you those bunch of pieces of paper? We have looked at 3 pharmacies in town and looked at the literacy level and readability level, and they're more high school level, and that may not work for everybody. So those are developed centrally at corporate world, and then it's used everywhere, like everybody will be able to understand this thing. And they're never tested. So this is the CE program. The Mexican drugs, a couple of things about it. We did use the Mexican PDR, unlike the US PDR is not a comprehensive list of medications. It's what's being promoted in terms of selected products that they want to sell. They're going to be mainly the brand names that still have a high profit. So that's what we use initially, but then we got all the resources. But a lot of what we're getting comes from patients. Now, this is an example of an ad that was in the newspaper here in 2006. And these 2 physicians, well, one of them is called doctor here, but the other one I'm not sure. but basically they say bilingual physician for consultation available at both locations. Now, if you take a look at this, El Paso Times, 80% of those drugs are controlled substance. And this is advertised in town for you to go and get some, do you want some amphetamines? Or do you want some narcotics? Or do you want some Valium? This is what I'm talking about. This is a product. Okay, real quick. This is a product that a patient brought to us. Can you read the name? Milagrosas. I mean, if it's a miracle drug, I'll take it. That's supposed to be for pain. And one patient came to us that was taking this product. That was not in the PDR, by the way. And a diabetic patient, if you look at these ingredients in here, phenylbutazone is no longer available in the US because gastrointestinal bleeding. So it's a non-steroidal anti-inflammatory agent. Metocarmamol is a muscle relaxant. Betamethasone is a steroid. What do steroids do to diabetic patients? They shoot the glucose off. So this patient was out of control and was taking that medication from Juarez and was given by a clerk because there are no pharmacists over there. Supposed to be a prescription drug, but sold without prescription because they don't enforce the law. This is an example of what was in the previous page. Adepsike. It has a antidepressant, antipsychotic, and a sedative agent. So that will take care of any conditions. Psychiatric. So what we have done is develop a database, and it's in our website. So people can go and look up some of these products that we consider high risk. It's an ongoing process because we find new products, we will add them. But that's basically what that is, because we think that this is an issue. We have a risk here. This is what the webpage looks like, and there is a specific information about certain drugs. Do you have any questions? Sorry, then I have to speed up.
What is the website?
Well, the easiest way to get to my website, I put it in one slide there, and this is going to be in the Health Disparity website in terms of the presentation. But the easiest way is you go to utep.edu, College of Health Sciences, and Pharmacy. And there is a link there. One of them has information about herbals, and the other one has information about Mexican drugs. Well, we actually combined them because it was easier to add to the existing website on herbal products. And there's other information in there that may be of benefit to you. The other way to do it is go herbalsafety.utep.edu. And it has more information than herbs. Yeah.
I'm wondering about the cost of those combined drugs that are illegal. Were they very expensive?
No, they were not. They were very affordable products. I mean, you know, the one thing about the law over there that we don't understand is that all those products require prescription.
Yes, they do.
But the law is not enforced. There are 6 categories of medications in Juarez or in Mexico. The first 4 require prescription. But the class 4 is where you have antibiotics, antihypertensive, you can buy hormones, and the law requires that the patient presents the prescription but keeps the prescription. So how will you enforce that there was a prescription written when there is no documentation that they have to keep? Now, class 1 and class 2, there are controlled substances, so that's why you need some of those drugs that I showed you in the ad. You do need a physician to write the prescription, otherwise they have to have something there. But they supply the physician, so you're in pretty good shape to get the controlled substance. And by the way, when you come back across the border, there's no standard from customs on how to handle medicines. There's no written policy. One thing that we know is that most of them say, well, 90-day supply is okay. But do they know what's in these things? Are they trained to really understand this is a drug of abuse. How are they getting it? You know, how do they screen it? There is no documentation what people are claiming, and we know most people don't claim. They just drive across, bring it back. Medications, you cannot smell it like marijuana and cocaine. You know, those, they have the drugs and other things that they're looking for, but the box of medicine, you know, most people would just bring them across. Okay.
How do you deal with the conflict of, I mean, we know you can post the stuff that's bad or that they shouldn't be buying, but how do you deal with poverty and people that don't have money to otherwise get something? If there were a good herb or something comparable in Mexico that would work for
Okay.
them?
I tell you, by law, anything from Mexico is illegal in this country because it's not approved by FDA. But we do know, and this is what I think, you could, I'm not endorsing this, okay, but I do think that this may be an alternative for some people, and I don't approve it, but if they go across, they should know what they need. They should not be asking recommendations from the clerk, because there is no pharmacist or professional, it's a self-trained clerk. So they may get some knowledge, but you should not go there and ask, what should I take for my knee pain? You know, but if somebody has a prescription for lisinopril for hypertension, they cannot afford it. Well, that's generic now, but maybe another one that is more expensive. They could get the lisinopril if it's a reputable pharmacy. There is another problem with the products everywhere, internet, Mexico, in Canada, and even in the US, which is counterfeits. So if somebody's out there to make money, they may be giving something that is not what it is. And so, but there are some well-established pharmacies over there that you probably can trust, but it should be something that you already know what you need. Not that I'm encouraging this, but I think that that will be the alternative versus you go there and say, you know what, I have a cough or a cold, I have a fever. They will give shots. Shots are common. Gentamicin shots. You're a nurse. One single shot in an outpatient basis, what would that be for? But they do that. So injections are common also over there. So, okay. Thank you.